Okay, our next section, and you're probably happy to see it, is problems with data collection, and that's what I was alluding to at the end. Um, Now, I want to talk about data collection in general. That we have two primary data sets, or we have two primary types of data. We have secondary and primary data, and both data sets have problems, but a secondary data set means that the data is collected by somebody else for their purpose, and then they make it available to the public for other uses. And agencies that do that would be the Centers for Disease Control, and there's some very famous data sets that one can purchase, and I don't want to go into that here, but you wouldn't have any problems identifying them. And in their primary data sets, these are cases where people collect their own data for their own specific purpose, and often we think that occurs for a dissertation or a thesis. Now, in some departments on campus, a secondary data set meets thesis and dissertation requirements. So we should not believe that it's totally necessary to collect your own data, that you can use the data of others. And I'm going to talk to you about secondary data sets, and there's all types of them, and that's why I'm not going into detail at this moment. Now, I want to talk to you about bias. Bias is error, and we have a lot of error. In other words, anything that diminishes or takes away from the fact that we have confidence that this is a true score, this is a true indicator of how somebody functions, has to do with bias. Um, Let me give you a few examples, like volunteers. That has to do with people that aren't trained, that or the potential of not being trained, so they aren't intentionally trying to collect data in a way that is unintended, but they do so. And we have another type of bias, like selection bias. Sometimes you only get a few participants who are not particularly motivated or overly motivated to tell you or they want to tell you what you want to hear, or because they are already engaging in a behavior. And the ones you're really interested won't participate because it's a non-issue for them, or it's too much work, or there's too many problems involved. Incentives often increase with the response rate. In other words, we get more people to participate, and research shows that incentives do not have to be large, but people must think they have a chance of receiving the incentive or winning. And if you sign up for something and you have a chance out of 100, you think very carefully about whether you want to engage in that activity. Now, let me talk about selection bias. And probably the clearest case is exercise studies, where the people we really want to reach are those people who don't exercise, but the people who enroll in studies are the ones who do. And so what are you really saying? I mean, if you're talking about health risks, which that's what we're interested in, um, it's we're probably missing the boat very, very badly. And I want to talk to you about another type of bias, is response bias. And sometimes people just tell us what we want to hear. And so the way you phrase a question often um, has to do with whether you're going to get truthful information or not. Um, Sometimes we get a low response rate. We have too few participants to test the hypothesis and make valid conclusions. And in this case, we do power calculations to make certain we have an adequate number of participants so that we can draw valid conclusions. So the tests, the statistical tests, have um, are producing a meaningful result that can't be contested. And so what we're trying to avoid is type 1 error or false positive, reporting something that, or not being able to detect something that really does exist and is really true. And so we're trying to avoid a false negative. So those are just um, examples of some of these problems, and sometimes what we run into is that a survey is time consuming or exhausting. It's long. It's got way too many items. It's got 200 items, for example. Well, that leads to fatigue, and people tend to answer in those particular um, ways that they just you begin to find a pattern in their responses. I'm sorry I wasn't keeping up with the screen for you. I know you have slides, so hopefully that will be okay. And then another common one is inadequate supervision. The person administering the questionnaire is untrained or poorly trained, and they're often responsible for training other people. And of course, then you have a catastrophe because nobody really knows or is familiar with the training or the survey instrument. And so they don't ask the question the way that it was intended. So those are just examples, and in the book, the definition, I think it's called A Dictionary of Epidemiology. Porta, the author of that book, if you look up bias, he has about 21 different types, and I think I get to those later on, just to let you know how many different biases there are, or how many different ways you can draw, how many ways that that can result in invalid conclusions. Okay, let's talk about interview survey problems. Now this is oftentimes we're talking to people, we're gathering ethnographic data, and it's called a number of different things, but it comes from ethnography. And so what we're doing is we're collecting data, much like data that's collected in a physician's office, where they may not fill out a survey, but they're going to, or they do fill out a survey or health information, and then they come in and talk to the practitioner. And so they're asked questions, and we find out that oftentimes people are poor historians. So the person may not accurately recall an episode of illness. I know I participated in a national study where the interviewer came to my home and asked me all kinds of questions pertaining to the illnesses of my children. And I had a very difficult time answering those questions because I was not the one who took the children to the physician. Another example is participants may correctly state the facts and the interviewer may record the facts incorrectly. So this is this training element. And if we find that with psychometrics and young people learning psychology and testing, standardized testing. There's a lot of training that goes on in asking the question accurately. In other words, they memorize the questions and they memorize the scoring criteria. And the interviewer may not ask the correct question, or may ask the question incorrectly. So these are all problems, and these are all problems that have been noted over time and are problematic. And let me catch up again. I'm sorry, I'm going to have to do better in keeping pace here. The next thing I want to talk to you about hospital data problems. First off, we have to remember that hospitals are normally not designed to collect data. Data collection doesn't happen in a systematic way, and forms are not constructed in a way to collect data so that we can identify determinants, agents, etc. However, research and teaching hospitals, that's generally the case. So some hospitals make that a great priority. So I don't want to have that be a generation, where I have generalized to all hospitals. And we realize that hospital admissions are selective, usually restricted to those who can pay, and so they're not a representative sample. Emergency rooms, however, usually turn no one away, and of course that increases medical costs, and it's passed on to those people who can pay, and it increases wait time, death rate, etc. dramatically. I mentioned that records in a hospital usually are not designed for research. Another factor is the incorrect diagnosis, or no diagnosis at all. If you look through medical records, oftentimes you don't find a diagnosis what the person's being treated for. And of course, I think that's very important, and it was always important in traditional medicine that diagnosis was to inform treatment. And somehow we have gotten away from that, and we haven't used the proper screening tests or serological methods or whatever to come up with appropriate diagnosis. As one physician told me, I use a broad spectrum medication, and if it happens to work, then I know the person has any one of a number of problems or diseases. But that's not the way normally we would want to work in a scientific way, and maybe it's cheaper and faster, and you all know the politics about hospital care and what goes on at the national level and trying to reduce costs, etc. Now, the population at risk may be defined incorrectly, so the denominators at risk. For example, we may not know correct state clinic statistics because we don't have an accurate idea about the population at risk. So with the case fatality rate, we have to have a diagnosis, and remember the case fatality rate is those who have a disease those who are ill over those who have the disease. So, or we may not use the correct statistic to answer the question that we intend to. So there's a lot of errors, and what I'm really trying to get at is doing an exceptional job and keeping track of important information. And I know that's difficult because there are so many tasks that are expected of our healthcare professionals today. They're just overwhelming. Um, Often a shortage of people, but not a shortage of issues to address. Now, morbidity report problems. Um, for example, lack of reported cases, like sexually transmitted cases, so we have a response bias. Now, I can tell you that in the hometown that I came from, the mayor's son had HIV, and this was early in the process. It was in the 80s, and what they did is they reported that as pneumonia. So he died of pneumonia. Well, he did actually. The primary cause was pneumonia, but the secondary cause was HIV. And so this is an example of response bias. Now, in reporting morbidity, and this would go into the MMWR, we have poor timeliness in reporting. If we have a sexually transmitted disease, as you know, that information is passed on with the patient's name to the local health department. Then it goes to the state department, and at that point, the name is stripped, and then it goes on to the CDC. So the reason the name is identified is because we want to contact partners and make certain this disease, if it's lethal, doesn't get spread. And of course, we don't want sexually transmitted diseases spread anyway. Um, and many people you have met feel that they don't have a problem. They don't like physicians, or they can't afford physicians, or it's an inconvenience to go, or they're working all day, so there's the availability of health care is difficult for them. So the case doesn't get reported because they just simply do not attend. They don't go in for medication. They figure that their immune system will ultimately manage it, and they will build immunity by dealing with it in their own means, or they don't deal with it at all. Is what we're really talking about. But they, if you will, they hope to wear out the disease. In morbidity reports, another problem is patients are diagnosed incorrectly. Now, Onkerson is a program that's interesting at Stanford, that they where a physician or a nurse or whomever inputted data about cancer patients, and they input it into a data system, and through this input of data they came up with a diagnosis and a treatment plan, and the program also identified areas of research that were missing that would help the overall validity of the system in diagnosis. Well, even in the early stages, they found that the computer did a better job of diagnosing than did the practitioner. So that helped with diagnosis accuracy. And sometimes we're dealing with insufficient sensitivity and specificity. So you already know about sensitivity and specificity, and those being the two most important terms for a screening test, because they lead us to the validity of the test. And we have a lot of people who do not know what they're doing in developing a screening test and training people to give the test properly, and or there's poor or no agreement upon the diagnostic procedures. Sometimes that goes on, so the screening test is not developed in a systematic way about what the criteria are for the particular medical problem. And I mentioned that with HIV, we had that problem where we started out with a particular set of diagnostic criteria, and then in 1989 we changed them. So all the data from 1980 to 1988 were unusable. So that really causes a problem. And I'm also really addressing that we want to make certain the reliability and validity and other psychometric properties of tests are evaluated and taken into account. Now, this is not a class on test construction. Be happy to teach one on that topic that you ought to know about in developing a proper test that meets psychometric standards. Burroughs, B-U-R-O-S, Mental Measurement Yearbook has tests in it that have been evaluated on several psychometric criteria, and you can access that through the library system, and I would encourage you to do that. Okay, anyway, now we have another error, and this happens especially, I'm talking really more about the census. It's undernumeration and misreporting. And undernumeration is undercounting. And sometimes when we have gone door to door in the past, or we send postcards, not all people are registered with the government in any database. And if you go to door, they will not tell you how many people are really living in the home. So this is a good example of under enumeration. My grandfather was an under numerator. During the Depression, he would go for a job, and they would have an age category, so he would give them whatever age category they needed so that he would qualify for the job. And then one day I asked him, I said, well, Grandpa, how old are you? And he says, well, he really didn't know. So actually, maybe that's a better case of misreporting than it is of undernumeration. So he would report his age at whatever it needed to be. And so if you were going to ask him to complete a survey, you would not get the correct age. And of course, we report ages in different ways. If you're an Asian and somebody is born in December, they're 1 year of age, and then the next year they are 2. So age is not necessarily something that's easy to count either. So all right, so I hope I've given you some idea about undernumeration. People don't want to get into trouble, obviously, with housing authorities. Oftentimes, multiple families live in a house. They don't want to record that there are too many people living there, and then the reporting of aging and why that might go on, or a reason why that occurs. So these are two common terms in epidemiology that I thought you ought to be aware of. Now, these are considered response bias, undernumeration and misreporting. And response bias means telling somebody what they want to hear. And both correspond to errors in the denominator. And so if you're trying to collect accurate information about any of this type of information, you're starting off with false information, and sometimes it's intentionally misrepresented, and other times people just don't know and they want to answer the question. You know, we're taught in our society, if somebody asks you a question, to answer it. Well, really that isn't necessary. If you don't know the answer, you probably shouldn't be trying to provide an answer. But that's our training, and that's uh, what society expects. Now, I'd like to talk about mortality data problems. We've been talking about morbidity and mortality, and of course, we're always interested in trends in mortality. And these are the errors in the numerator that causes problems, and I've been talking about these all along. And not only errors, but just simply not knowing what the diagnosis is, and the interviewer not reporting them properly, and changes in rules and changes in classification, and a couple of denominator errors. Errors in the population at risk have to do with underreporting and misreporting. Okay. Now we have mortality, death problems with death certificates, classifying the cause of death. And I'll show you this, that I already mentioned the case where the mayor's son had died of HIV, but it was a politically sensitive issue, so they classified the death and reported it in the newspaper as pneumonia. Now, it wasn't a lie, but it didn't look at the underlying cause of death, and usually what we want to report is the underlying cause of death and not the immediate cause of death. And sometimes it's just simply difficult to tell what the cause of death is. Now, we know too, and I know you know this, that pneumonia is the fifth leading cause of death among the elderly, and it's related to, they call it the death angel. And it's those who have suffered from some kind of prolonged problem. The last thing that causes their death is pneumonia. But anyway, the first cause of death in this situation that we were talking about, or the underlying cause of death that I want to get to again, was HIV and not pneumonia. So we have multiple causes of death, and our forms aren't set up for multiple causes of death. They're set up for a primary cause of death. And oftentimes the reason for the death are not listed. They give a statement, and I'm going to show you death certificates that because this is where we collect our mortality data. So if those death certificates aren't completed properly at the hospital or by the medical examiner or wherever, then you have a misrepresentation of the circumstance or situation. Now, cases that require an autopsy. I thought this might be of interest to you. Anytime there's a fire, we do an autopsy, and homicide, and bathtub drowning, antifreeze, or whatnot. Apparent suicides that are without clear evidence of intent, drivers in single car accidents, or if you are driving a commercial vehicle, they are going to examine what happened, and pilots involved in aircraft accidents. And I'm going to come to a conclusion here that as I'm going along here. And so cases that require an autopsy death too are occupational death and unwitnessed accidents and sudden infant death. And the main issue is litigation, and the main issue is whether an insurance company has to pay out in terms of a death certificate if somebody has to pay out if somebody has died, and because that's what they're trying to avoid. And if you've done something to um, make yourself suspect in the way that you died, for example, an overdose of drugs, or you were operating equipment by taking illegal drugs, or you were legally drunk, or any number of other things, then the insurance company is off the hook and they don't have to pay those fees. And just to let you know that 70% of the world's lawyers are in the United States, and many of them are unemployed or underemployed. So sometimes we have litigation that is frivolous, and there's plenty of opportunities in looking at deaths to make certain everything has been, all the relevant data has been collected and collected properly and is not contaminated and is not lost, etc. All right. Now, sources of mortality data. Well, we have census data, and it's collected every 10 years over three years. So, if we're going to look at census data, we begin with let's take 2010. So we'd start in 2009 and we'd end in 2011. So, in the data that we use in most of our statistics is the median year, which would be 2010. And people say, well, why is that? They figure that that's the most accurate data and that's the largest number of cases that are collected, and so that's why that year is used. Now, in between time, what do we do if we come, we're doing a survey that doesn't fall on a census year, or the census data appear old to us? They have a current population survey, and it's a monthly survey of about 50,000 households conducted by the U.S. Census Bureau for the Bureau of Labor Statistics, and it's been in effect for over 50 years. And so it's not as good a source, but it is an available source by which estimates can be made based on this data. So, much smaller number of cases, but the number of cases isn't always what's most relevant. For example, the Gallup poll only includes about 1,600 people, but the difference is they're asking a single question normally, or just a few questions about who's going to be elected, and their degree of accuracy based on their sampling methods or sampling frame is between plus and minus 3%. So it's not necessarily how many people. It's the quality. It's the quality of the sampling frame that makes a difference to obtain a representative sample on which we can draw conclusions. Now, if we can verify that sample, for example, we did a study here at Purdue where we took a certain percentage of students and then we could verify it against the total number, and we found out that our data of this sample was very close to the census data, and then we had more to say. We were in a better place to talk about external validity or generalizability. Okay, other sources. I should say the source of mortality data, the CPS is also the main source of information on the labor force characteristics, and you can find that information on this particular website. Sources of mortality data. We have the Vital Statistics Register, and it's published every 2 years, and the registry collects and processes and birth certificates, death, marriage, and records. So when we talk about vital statistics, we know that to be everything from birth to death. So we talk about birth, we talk about marriage, we talk about separation, we talk about divorce, and we talk about death, right? So, and all of this is based on a certificate. This is a one time in your life where you don't have to work too hard to get a certificate, but they are collected as you go through life. Um, the National Death Index is a computer file of all deaths in the U.S., and you can Google these things and they'll come up. One of the best sources of data is linked birth and death files. And as technology improves and there's more linkages between states, we're going to be able to connect where a person was born with where they died. And that should be very illuminating and generate hypotheses about some diseases. I know that I was asked about a case here locally about why people seem to be dying more often than in other locations. And we took two groups of people. We had a hypothesis, and we looked at power lines and whatnot, and we looked at residents that had always been in this area and those that lived under power lines for different numbers of years versus those who lived elsewhere. And was the determinant power lines, in this case it happened to be. And so we had their birth record because we had to make certain that the people were all from the area, and then we had their death certificates. So with that, we were able to do a reasonable study and look at prevention, protection, and control. Now, the difficulty with it is, of course, in linked health records is people's birth certificates may be on file in one jurisdiction, their marriage certificate in another jurisdiction, and their child's birth certificate in a third. What we'd like to do, and I don't know whether this will ever come about because of the expense, is store all of your records in one national file that pertain to you on vital statistics, and then see what conclusions we can draw. Let's see, they did the Stanford Morrell study on people who belonged to Mensa. In other words, people with an IQ of 160 and over. And that was an interesting study, and they had all of these people that they could get, and they had medical records and all kinds of records that they had been able to obtain because the study group wasn't too large, and they could answer questions whether or not there were more divorces or whether they had a better quality of life, and whether what impact did being brighter have on longevity. Very interesting study and very interesting results. Now, some states do link birth certificates and death certificates for children who die within the first few years of life. We have cancer registries in some states, which is very helpful. And again, there's the possibility of integrating birth and death data into one recording system is appealing but expensive, and there's all kinds of complexities because this data comes in different formats. Every state has a different form for a death certificate, and oftentimes the fields are not the same in which you record data. So to try and do a comparison means that the data have to be all organized consistently, and so you have you have the same variables in the same columns. Otherwise, you've just got a mess. And so that's one of the things that makes this kind of data expensive to collect, but very appealing and very important. Now, oftentimes we're talking about problems with our collection of data, and we think that the classification of deaths shouldn't be difficult. It ought to be straightforward. Everybody knows their family history and heritage, and I can tell you that is not the case. I remember in the 90s, for example, there were 99 different dialects, spoken in San Diego. And when the public schools wanted to do testing on children, they had to have an interpreter for each child to talk with the families as well as to test the child in their native language. So you can see that that was an overwhelming task, and to identify competent, capable, educated folks, and they didn't want to pay them a lot of money, was a difficult job. Now, for the first time, the 1980s census collected data on the following groups: Black, white, Japanese, Chinese, Filipino, Korean, Vietnamese, Asian, Indian, Hawaiian, and here you go, right? So, and some of the data were collected for the first time on Asians. So we had a change in the numerator. But coming up with agreed upon definitions of what constitutes a particular race is left up to the individual. And we'll talk about a difficult case in terms of when we talk about races. Now, we mentioned that Koreans and Vietnamese were considered in the census after the 1980s, and what brought that about is we had boat people that came over from Vietnam and from Cuba and other places, and we sort of, the Cubans were already taken into account, but we were beginning to realize that our racial categories were insufficient. Now, another difficulty, and I don't know whether you know it, the Spanish Hispanic category can have as many as 17 different subcategories. So you can have a Mexican, Puerto Rican, Spanish from Spain, and Cubans, and anybody that is of Spanish or Mexican descent often is very clear about the differences and what qualifies to be one versus another. Today, it's still common to see many government reports presenting data for just a few, and for 4 categories such as white, black, American Indian, and other. So, well, you say, well, is that so bad? You know, we should be homogeneous. We should be accepting of each other. I don't disagree with that. That's very important. Nobody debates that, I think. Well, excuse me, some might. There are groups that do debate that. I'll correct that statement. But we know that some diseases go with certain nationalities. And so it's important to begin to distinguish nationalities so we know what diseases are more likely with that nationality. That would sure help a healthcare provider. And it would help the census, and it would help with what? Prevention, protection, and control. Okay. The point I'm trying to make is that race and ethnicity are controversial And you know that just from your own life experiences. And it has required a great deal of thought and how we're going to report data and consistency in data and changes in our country and societal norms. But I'd like to read from you from this particular page to help you understand that they're trying to make progress in racial classification. In 1997, the OMB announced new standards for federal data on race and ethnicity. Following the OMB standard, the 2000 census used the 5 suggested racial categories: white, black, African American, American Indian, Alaska Native, Asian, and Native Hawaiian, other Pacific Islander. The Census Bureau also added a 6th category, some other race. The Native Hawaiian Other Pacific Islander was separated from the Asian category for the first time. A second and even more influential change allowed respondents to choose more than one racial category. Heretofore, you couldn't do that. Prior to the 2000 census, the U.S. Bureau of the Census conducted several tests, including the 1996 Race and Ethnic Target Test, to consider the implications of changing the way in which data were collected for the counts of racial and ethnic groups in the United States. The major conclusion that came out of this test was that allowing individuals to choose more than one racial group had a very small impact on the measured racial composition of the population. Now, even though this has gone on, there are similar problems in reporting most demographic information related to distribution. And oftentimes when we look at religion, we take the 4 that are often on government reports that are reported here, and devoutness often is not recorded, and others believe that devoutness may be more important than a religious category anyway. So just to have you think a little more broadly, and again to recognize that this is still a problem in what religious groups do we include. Next, I want to talk about death certificates, and this is how we get mortality data, and this is how we generate statistics about mortality, and these are the statistics that we use in mortality. And I want to talk about the death certificate and classifications. I want to show you examples of death certificates and the ideal way that deaths ought to be recorded. We know that the death certificate is the responsibility of the attending physician. That's common knowledge. Most of you are aware of that. The problem being is that when the death certificates were first thought of, they figured that one physician would probably treat a patient throughout their lifetime and would have a full history of that individual. Now, for example, if you go on spring break or somebody goes on spring break, the attending physician happens to be the one that's probably somebody in an emergency room that doesn't know you. So they don't have a history which impacts and affects the way the death certificate gets completed. But anyway, a part of this process is somebody must pronounce the patient dead. And they come in and they're going to pronounce the patient dead, and the death occurred at such and such a time on such and such a date. So it's an official process that goes on. And it sounds maybe a little silly, but we don't want to bury someone alive. And let me just tell you a personal anecdote is that we don't want to bury somebody in the wrong grave. I've had a situation where they had to exhume the body because the person, a family member, was buried in a grave that was not designated for them. So we have to have the death certificate for burial, but you ought not to assume that that person is going to be buried where you have intended or designated that they be buried. So your constant vigilance over this entire process is important, and oftentimes it comes at a time when you're going through a lot of emotional trauma and change and whatnot in your life. But it's important that you not rely on everyone else in this process, including the mortuary or the cemetery. So again, I'm saying your involvement is critical. Don't take anything for granted. Now, I want to talk about death certificates. What we have is we have an underlying category, and then we have an intermediate cause, and we have immediate cause of death. And this just happens to be the ideal way that a death certificate should be completed, and I will show you one, and I will show you often how they get completed instead. And I would like to just say that allergies are as serious as type 2 diabetes. So for those of you who are allergy sufferers and people make light of your particular disorder, you have an important problem that causes all kinds of consternation and difficulties in your ability to function and has an effect on your energy level. Okay, so here's an ideal way that a death certificate ought to be completed. Okay, here's another ideal, and we run from the underlying cause to the immediate cause. Now notice this would require some kind of history, and this would assume that a person has probably seen the same physician for their lifetime or a long period of time, and oftentimes I can't remember the exact statistic, but about 80%, or I know it's greater than 50. Let's just say 50% of the country moves annually. So sometimes medical records are consolidated, sometimes they are not. Sometimes people choose not to send medical records because they want the physician to have a fresh view and fresh approach with whatever problem that they're encountering. But if we could have every death certificate completed this way with the underlying cause and then the immediate cause, this would be the way in which it would be done. This would be the ideal way in which it would be done. Okay, next. I thought I had shown you that. Excuse me, I did. And now I want to show you a death certificate that is used by the Indiana State Department of Health, and this is a sample, and you can see all the information that is completed. And right down here in the certificate is where we have the 3 levels of that we would want reported. So we would have the underlying cause as C, and the intermediate cause as B, and the immediate cause as A. And as you can tell in looking at this, this was a single car accident. So an autopsy um, uh, um, should have been done, because anytime you have a single car accident, that's what they do. But you notice what they listed as the primary cause of death was multiple fractures of the skull. Okay, and someplace I think it indicates on here whether or not this was an automobile accident, and that's right there. Okay, so in this particular case, you don't have any other factors that led to it, although they may have influenced the person's ability to operate a vehicle carefully and avoid a traffic accident. Okay, and I know in this particular case the person had other medical problems that would influence their capability of driving. So there are no C and B listed, because what we want to report to, we're going to report to the county health department, then we're going to report to the state department, then the name often is stripped from it, and the information goes on to the CDC, and this is how we make up those people who die from injury, and it can be, as you know, from an automobile accident or a bicycle as a result of not wearing a helmet. Next, I would like to show you another example, and you can see that it goes through and it lists the same information, and you can study this death certificate if you would like, but they only list one thing. They list breast cancer, and they did, and it was in 3 years, but they don't list the intermediate cause or the underlying cause. Now, something has to be a result, has to be a determinant or the underlying cause of breast cancer. But this attending physician had no idea about the patient's history and didn't include this information. So what gets reported is carcinoma or cancer, so the person died of cancer, and sometimes we have the specific cause of cancer, and other times that information is not even listed either. So how well the death certificate is completed has determines the specificity of the type of data we can report and the type of data we can collect, and so we can have a better prevention, protection, and control procedures.